Welcome to Eye Contact. I'm Henahan. Cataract surgery in patients with high myopia can produce dramatic improvements in vision, but the surgery carries extra risks. Today I'm very pleased to be speaking with Dr. Soosan Jacob, who will tell us everything we need to know about phaco and high myopia. Welcome, Soosan.
Thank you, Sean.
What are the challenges presented by phaco in highly myopic eyes?
Right. So when you refer to high myopes, Sean, it refers to patients who've got an axial length more than 26 millimeters or a myopia more than -6 diopters. And these patients are at a higher risk for many problems such as retinal detachment. So you could have pseudophakic retinal detachments postoperatively, and that's the reason why every myope before undergoing surgery should have their retina examined, and if there are any weak spots, they should be lasered. Also, they could have macular issues such as CNVM or just macular atrophy, chorioretinal atrophy, and all these things, which could again limit the potential vision that they are going to get after surgery. And also post-operatively, these patients could be at a higher risk for being steroid responders, which could lead to an increase in the IOP post-operatively. So that's another thing that you have to keep in mind when you're treating them post-operatively.
So you're talking about a very comprehensive pre-op assessment.
Absolutely.
How do you deal with the risks associated with the anatomy of those eyes as you're getting ready for surgery?
So one of the things that happens when you're doing these myopic eyes is that as you go in with your irrigation aspiration probe, or even as you go in with viscoelastic, the entire equator expands, the zonules expand, and the iris lens, iris diaphragm and the lens are pushed backwards. That's called the lens iris diaphragm retropulsion syndrome. And what happens is that you get this reverse pupillary block. The whole anterior chamber is very deep. The patient, if it's under topical anesthesia, has pain suddenly, and you find that you're suddenly forced to work very vertical because everything is way down, and your focusing range of the microscope really has to keep changing. You have to keep adjusting it because the lens is so much down that it's really difficult to work at that angle as well. So a very simple trick to get rid of this is just lift up the iris a little bit at one point and let the fluid from the irrigation probe just enter around that space under the iris, and so it just equalizes the pressure differential between the areas behind the iris and in front of the iris, and that kind of gets rid of that problem. But it's going to happen every time you enter in and come out. So you have to what you can do is just put a rod before you enter between the iris and the lens and just lift up the iris so that when you enter the fluid, it's automatically readjusts itself everywhere rather than just being in the antechamber alone.
And that will simplify actually removing the lens.
Absolutely, yeah. Yeah. So there are also other things that can happen in these high myopic patients. You have to remember that they have low scleral rigidity, so their corneal tunnels may not be as well constructed or well maintained as normal patients, and then you generally also, because these eyes are larger, you do end up working a little bit more vertically, so your maneuvers may be more difficult. You have to remember that they have a larger anterior the cornea, so you can sometimes get misled by the size of your rhexis. You may make a normal size rhexis, which is the right size, but you compare it to the size of the cornea and you feel it's very small, and you may go ahead and enlarge it a bit more, and then you find that it doesn't give you that optic edge covering all around, and your optic is completely not covered all around, and the rhexis is larger than the optic. So these are problems that can happen, and if that happens, the optic can come out. You can have posterior opacification. Post-operatively, you might have to do a YAG laser for that PCO, and then that could lead on to a retinal detachment. So these are things that you have to take care of. Also, you have to remember that the vitreous can be syneretic in these patients. Some of them could have had an RD surgery previously, vitrectomy is done previously. So these are all things that add on to the complexity of surgery. And one thing that you always have to make sure when you enter and come out in these eyes, you do not allow the anterior chamber to fluctuate. So that's extremely crucial, because the more fluctuation you have of the anterior chamber, the greater chance there is of developing a retinal detachment post-operatively. So if you're coming out, inject viscoelastic with the left hand and come out, and also of course the newer machines with active fluidics are extremely helpful in maintaining a formed anterior chamber.
Well, how do you deal with the risks associated with the anatomy of these eyes?
Yeah, that's a very good question, Sean. These eyes are large, and there's a very peculiar phenomenon that happens when you do phacoemulsification in these eyes, and that's the iris, the diaphragm and the lens retropulsion syndrome. So what happens is when you go in with irrigation aspiration probe, the entire anterior chamber fills, the lens, the zonules stretch, there's a backward movement of the iris and the lens, and that makes the anterior chamber very deep, and there's a reverse pupillary block that's created.
I also wanted to ask about flax. Where does that fit into this equation?
Yeah, so flax is something that can also help in a myopic eye, in the sense that you don't now have to worry about whether your rexus is accurately sized, because you're not eyeballing it. You have the measurements in the machine, and that gives you the right accurately sized rexus. So that's an option that can be used if you would want to, though there are simpler ways of doing it by just putting a mark on the cornea and things like that. You could also use it for nuclear disassembly, which means a hard cataract can be femtolasered and made into smaller blocks, which can be removed easier, but I think most of it can be done with the normal routine phacoemulsification with your own 2 hands.
So on a larger level, what do we know about the outcomes with these eyes? There's a concern about retinal detachment. Is that still a problem? Is it less of a problem than it was?
Yeah, I think as I said, with the newer machines which have active fluidics and very stable, you get extremely stable anterior chamber conditions. None of that shallowing, none of the surge, the incidence, and the greater awareness, of course, among surgeons about how to tackle these eyes. All of this, and the need to do a laser before surgery, and all of this have become much more well entrenched in the minds of surgeons. So definitely, if you do a good job, the risk of retinal detachment is low, but you can never be absolutely sure because the patient may have a retinal detachment related to surgery, or sometimes completely unrelated to surgery, because he is a high myope, he has weak spots on the retina, and they could give way at any point of time. So you always need to counsel the patient about this possibility, and also always keep a very close look on the retina always.
Considering the risks, would this be an argument against clear lens extraction?
Yes, if you're doing clear lens extraction in a high myope, you definitely have to consider these situations. I would very seriously not consider doing it in a young patient, because you also lose accommodation, and these patients are so used to seeing small print without glasses, and they so love it, that if you do a clear lens extraction and you're not able to give them that reading ability, they will be unhappy, very unlike hypometropic patients who are happy because they couldn't see well at any distance. So clear lens extraction has to be thought about carefully before you do in a high myope, and also planned very well if you're going to go ahead and do it.
Well, thank you so much.
Thank you, Sean.
Thank you for joining us. For more information, please visit us at eurotimes.org.